Okay, so we're going to talk about congenital clubfoot deformity. Clubfoot affects about 1 to 3 per 100 or per 1,000 live births. It is definitely race related. Certain races are a little more affected than others. Caucasians are about 1 per 1,000. African descent about 2 per 1,000. And then Asian descent can be a little higher at 3 per 1,000. Males are affected 2 to 1 to females. There's definitely a hereditary component of it. It's 30% in monozygotic twins and 20 to 30 times as frequent in first order relatives when there is a clubfoot. It is presumed a polygenetic disorder. It's not affected by birth, weight, or maternal age. There are essentially two types of clubfoot deformity. There's typical and atypical. Typical is your otherwise healthy child. It's a positional clubfoot due to interuterine crowding. Delayed treatment is considered more than 6 months old before initial treatment. Recurrent typical clubfoot means they've had the Ponseti treatment in the past and it's come back. And then alternatively treated clubfoot is a post-surgical or non-Ponseti treatment. So those are subcategories within the typical clubfoot category. Atypical are problems associated with other problems. These are going to be more rigid or resistant type. These are usually associated with different syndromes, like arthrogryphosis is a very common one. They can be teratologic, congenital tarsal chondrosis. It can be neurogenic, meningomyelocele, or it can be an acquired clubfoot like Streeter's dysplasia. This is an example of a syndromic clubfoot that I saw in Haiti, and you'll be able to see, just as I try to reduce this, how rigid the baby's foot is. Just kind of the best way I can describe these syndromic club feet is they're kind of almost like a block of wood that are just out of position. You can see it's not coming over at all as I'm trying to manually reduce it. Pathological anatomy of clubfoot. First, the tail is short. The head is deviated medially and plantarward. The subtalar joints are distorted. The calcaneus is small, it's inverted, and it's rotated under the talus. The naviculus is also small and rotated medially, and it's often almost forms a pseudo articulation with the tibia, and it's called the tibio-navicular joint. And this can really be a limiting factor when you are talking about surgical correction of clubfoot. And I've actually seen people who are not well versed in clubfoot surgery take out the navicula to try to get the foot over, and it results in pretty devastating long-term results to the foot if you can't destabilize the medial column of the foot like that. Their other bones, soft tissues are normal except for secondary contractures. Here's a child that has an untreated clubfoot that is walking. You can see how the foot adapts and it becomes rigid to where they're walking essentially on their talar heads almost. I'll replay this again so you can watch it, and you can see how the foot turns backwards. The kids almost walk they will wear their shoes backwards sometimes as they get older, and the deformity becomes more pronounced and more rigid, and adapts to the position that it's in as they're walking. It's important to understand the different components of the clubfoot, because when we start talking about the Ponseti method for treating it, we have to address the components simultaneously, but you need to understand all the components that are there. So first, there's equinus, which is pretty self-explanatory. It's plantar flexion at the ankle. Then there's forefoot adduction. The forefoot is adducted. Rear foot varus. There's a cavus deformity, which is a really complicated component to understand. The forefoot is actually pronated relative to the hindfoot, and when we start talking about the initial treatment of with the Ponseti method, this becomes a really critical concept to understand. So understand that there's a cavus deformity and that the forefoot is pronated relative to the rear foot or hind foot. And this is demonstrating that with these pens. You can see how the forefoot is pronated relative to the hind foot. And then there's supination of the entire foot. Yes, forefoot is pronated to the rear foot, but the whole foot as a unit is supinated. So why not just take all these patients to surgery? Clubfoot has had an interesting course of treatment over several decades. It was initially treated with Kite's method in the 50s and 60s. In the 70s, they were starting to realize that the Kite's method wasn't working very well, so they started doing a lot of surgery in the 70s and 80s. And then they started seeing why surgery was not working. This is an article by Matt Dobbs, who was a resident under Dr. Ponsetti, and they looked at long-term follow-up of patients with clubfoot treated with extensive soft tissue releases. And the conclusion were that many patients with clubfoot treated with an extensive posterior medial release have poor long-term foot function. They found a correlation between the extent of the soft tissue release and the degree of functional impairment. Repeated soft tissue releases can result in a stiff, painful, arthritic, and significantly impaired quality of life. When a child ends up with a pretty radical surgery like a posterior medial release, even though it's all soft tissue, we don't give it the respect that it deserves. It has long-lasting impairment for that foot. The foot becomes very stiff and dysfunctional as they get into adulthood. I see a lot of adults that have had surgery as children, and the lack of functionality of the foot is pretty pronounced. It's another study by Zwick that looked at the Ponsetti versus surgical treatment for idiopathic clubfoot. And at the last follow-up, the mean functional rating score was higher in the Ponsetti group. Passive dorsiflexion, passive inversion, eversion were better in the Ponsetti group. They were comparable in radiographic outcome measures. The trial documented a favorable short-term outcome for the Ponsetti method when compared to the traditional treatment protocol, which was a posterior medial release. Kite's method, this study in International Orthopedics looked at Ponsetti versus Kite's method, and Kite's method had a significantly higher recurrence and took longer than the Ponsetti's method. And they were of the opinion that the Ponsetti method was superior to Kite's method in achieving correction of idiopathic club feet in a row. Let's go back to Kite's method here. So this shows Kite's method again with using the calcaneus as a fulcrum and breaking through Lisfrancs and show parts. Like I said, the Ponsetti method is a series of casts to gradually correct the deformity, where you abduct the foot, which is stabilized beneath the talar head. All components of the clubfoot are corrected at the same time except for the equinus, and that's a really important concept to remember. The thumb of the hand is on the same side of the deformity is placed over the talar head laterally. The index finger on the same hand is placed behind the lateral malleolus. And then you move the forefoot laterally in supination with the other hand. You're going to hold for 60 seconds. So this is how you do the manipulation components. You're going to do manipulation prior to casting, and it's just repeating or mimicking the technique to correct the deformity as you're casting it. Here's a video that demonstrates how the difference between the Ponsetti method and Kite's method. Kite's method would use the calcaneus as a fulcrum. With the Ponsetti method, we're going to use the stabilized talus as a fulcrum. Then we're going to move the entire foot in supination and abduct it against that fixed talus. So here we go. And you can see how those red dots start to move and get back into position. And you're moving the entire foot as a unit around the stabilized talus. And watch how we're not touching the calcaneus, but watch how the heel comes out of varus by abducting the foot in supination around the stabilized talus. You can see how the heel comes out of that severely inverted position back to a rectus position. And you should never touch the calcaneus while you're doing the Ponseti method. That's a really important concept. The magic move is correcting that cavus deformity that we talked about as one of the components. Because the forefoot is pronated relative to the hindfoot, you want to make sure that you supinate it to get the forefoot and the rear foot on the same plane, and then you're going to move the foot as a unit in supination by abducting it against the stabilized talar head. And this is called the magic move. So in the first cast, it's almost going to look like you're making the deformity worse. But what you're doing is you're getting the front part of the foot and the back part of the foot on the same plane, because initially they're not. And this is what it looks like. You can see how the it looks excessively supinated. The equinus and the foot's in full supination, and you're correcting that cavus deformity, getting the forefoot and rear foot on the same plane. This is called the magic move, and this is a very important concept because you cannot really start abducting the foot as a unit until you get the forefoot and rear foot on the same plane. And it's the very first step in correcting the deformity. The second, third, and fourth cast is going to consist of adduction and varus, which are gradually corrected. There's no direct attempt to correct the equinus deformity. The calcaneus will abduct and dorsiflex under the talus as you're moving the foot over. More rigid deformities may require more than for this 5 or so casts. You may have to go up to 7 or 8. And then you change the cast about every 5 to 7 days. Characteristics of adequate reduction. First, the ability to palpate the anterior process of the calcaneus as it abducts out from beneath the talus. So you can feel the anterior process of the calcaneus. Abduction of at least 60 degrees from the frontal plane of the tibia. A neutral or slight valgus position of the calcaneus. And the Pirani scoring method, which is a really reliable way to determine when you should do or if you should do a tendo-Achilles lengthening. And that forefoot score is less than 1 and the rear foot score is greater than 1. And basically what that's saying is all the deformities in the front part of the foot have been corrected, but there's still a residual equinus deformity. This is a video of Dr. Ponseti doing the Ponseti method and with a tenotomy in surgery. I may fast forward a little bit because it's relatively long. I just want to show you his technique and him actually putting the cast on. So they have the foot prepped here, and they're going to do a percutaneous tendo-Achilles lengthening. With a beaver blade. This is Dr. Jose Marquindo, who took over for Dr. Ponseti. You can see in these infants' feet, the Achilles tendon is not as easy to identify as you would think it would be. So they're just doing a little block here first. Let's go ahead and fast forward through that. And so here they use a beaver blade. I like to use a 15 blade. You have to be careful that you don't get too low and get into the calcaneal apophysis, and you don't get too far lateral and get this sural vein. It can cause quite a bit of bleeding. Sometimes I'll make the incision a little bigger and almost use a small hemostat to kind of bring the Achilles tendon into the operative field to make sure I'm adequately releasing it and just cutting it and not anything else. But this can be done in a clinic setting. In certain instances, sometimes it's just easier to do it in the operating room under anesthesia. Otherwise, you can do it under a block. So here they're doing the other leg. It can be challenging doing these under a local. The kids are usually fighting you and trying to pull away. So you can see now they're getting ready to put the cast on. It's a layer of cast padding, or I like web roll a little better than cast padding. I think it's not as loose as cast padding. You can get a little more contour with it. And it needs to be a very thin layer. You do not want too much padding beneath the plaster. Otherwise, the plaster will slide. You want to have a good mold of the foot, almost like a total contact cast. So very little padding. You want to come out over the toes. It's important to come out over the toes planarly to stretch out the long flexor tendons, which also can be contracted as part of the deformity. So you want to have like a little platform beneath the toes. And this last cast is left on for 3 weeks. That's why they're getting it all cleaned up with all the prep off the skin there. You can see, again, just a real thin layer. And you're going to work in segments. The first segment's going to be below the knee. And then you're going to go above the knee once you get the lower segment on. I typically will go ahead and put the cast padding or web roll on first all the way above. You do want to really pad the knee up well when you are putting the web roll on. Even though the rest of it should be a pretty thin layer, when you're around the knee area, it needs to be a little more robust to just cushion the knee. So now plaster is the Ponseti method, not fiberglass. So here you can see they're putting the plaster on, and watch it. It's really almost a two-person job. You can see Dr. Merquindo is putting on the plaster of Paris, and he's going to mold it and contour it and shape it, while Dr. Ponseti is correcting the deformity. He's using his right hand to stabilize the talus, and he'll start to abduct the foot about, and you can see he's really molding the posterior aspect of the heel here. And he's getting the arch contour also molded in really well. And he's using his index finger, in this case on his right hand, to stabilize the talar head as he's abducting the foot in supination. Now, in this last cast, because the tenotomy is done, you're going to dorsiflex it also to correct for the equinus or deformity. Now you're going to go above the knee. You need to pad the knee really well. The knee should be basically at 90 degrees, or it can be anywhere between 60 and 90, but usually I just try to have it about 90 degrees. You want to go as far up on the thigh as you can get. And a Ponseti cast must go above the knee. Ponseti is not below the knee, and not a below the knee cast. You can see how they're out over the toes right now. They're going to cut back the dorsal part of the cast. So you do not want that on the dorsal aspect of the toes, but you want that platform beneath the toes. You can see they're coming up around the knee now. And kids can break the knee, so you need to have the knee reinforced really well. And if it's an older kid, you can use some splints, some anterior splints with just plaster of Paris, or if they're even older and stronger, you may have to reinforce the plaster of Paris with a fiberglass cast. It's really important to mold it really well and to get good contouring. You can see how he's molding the back of the knee area really well there. Nice smooth cast. It's not like it looks like the shape. Look how much abduction there is in that compared to the tibia. And so they're just going to do the other foot. That just gives you an idea of the technique. So the fifth cast or post-sternotomy cast, once the adduction, varus, and cavus are corrected, the equinus is treated. Achilles sternotomy is required about 85% of the time. The cast is left on for 3 weeks after the sternotomy is performed, and bracing is started when the cast comes off. And you can see the difference when you have corrected the equinus. You want that foot in a dorsiflex position as opposed to a slight plantar flexed or neutral position. So there's a breakdown of the different casts in the foot. With an untreated clubfoot, you're just essentially correcting that cavus component, getting the front forefoot and rear foot on the same plane. In cast 2, now that the forefoot and rear foot are on the same plane, we're going to start abducting in supination and plantar flexion against the stabilized talar head. And then we're going to continue to abduct and correct for that in plantar flexion, in supination, until we have full correction, except for the equinus. And we're going to, in cast 5, correct the equinus deformity and then hold that in more of a dorsiflex position. Some casting tips: you want to manipulate prior to casting just for a few minutes briefly, just to loosen the tissue up. Very thin layer padding, like I said, below the knee casting with the first wrap. You want to make sure you mold things very well. As you're pressing on the talar head, you want to kind of go on it and off it, on it and off it. If you continue to push on the talar head the entire time, you're going to create an indentation in the cast, and that's going to cause a pressure sore over that area. You never touch the calcaneus for correction, and you never pronate the foot. You're always supinating the foot. You're always supinating the foot and then moving it into abduction. The next cast must go above the knee. The knees flex between 60 and 90 degrees. More padding in the knee area and the thigh. And like I said, older children may need anterior reinforcement because it can break the cast pretty easily. You want to trim the cast dorsally to the MPJs, but leave that plantar shelf to stretch the long flexor tendons. I usually use kind of narrow, fine points, blunt scissors, just so I'm not going to injure the child. Dr. Poncetti used to use a cast knife. Those things are relatively intimidating, I think, and I think there's room to cut the child's toes. So while the plaster is still somewhat wet and trimmable before it gets rock hard, I will take the scissors and cut it back and follow the contour of the MPJs dorsally, just so there's no cast over the toes themselves, but you maintain that plantar shelf. I remove the cast in the clinic. I think that's really important because you do lose correction if they take it off at home and come to your office and the child's out of the cast for, let's say, an hour, hour and a half, 2 hours. The easiest way is to have the parents soak the cast for about 20 minutes in some vinegar water and then cover with a plastic wrap or trash bag prior to the treatment. Even if they wrap washcloths or something like that around the cast, wet washcloths, to keep it moist, and then a plastic wrap around that, it makes it very easy to get the cast off without having to use a saw and risking cutting the child. The Pirani scoring method, we mentioned earlier, there are 6 components of the clubfoot that are scored. The scoring components are 0, 0.5, which is considered a medium deformity, or 1, which is considered a severe deformity. The forefoot and rear foot are each scored as a set. So for the forefoot, you're going to have between 0 and 3 because there are 3 components. We'll go through each of them. And the rear foot's also 0 to 3. It helps you monitor progress, number 1. Number 2, it tells you when a sternotomy is indicated. Again, that's when the forefoot is less than 1. That means you've corrected all the forefoot deformities, but there's still a residual rear foot deformity, and that's the equinus part that needs to be corrected. Additionally, the Pirani scoring method is used for statistical analysis of clubfoot correction. So first, the lateral border, you're just going to place a straight edge against the lateral aspect of the foot, and you're looking at the 5th metatarsal base. If the flat edge goes all the way up to the 5th metatarsal head, that's a 0. If it breaks distal to the 5th metatarsal base, that's a 0.5. And if it breaks proximal to the 5th metatarsal base, that's considered a 1, away from that lateral edge. Medial heel crease, no crease is a 0, a very superficial or shallow crease is 0.5, and then a deeper crevice on the far right, is considered a 1. Lateral talar head protrusion. You can almost see the lateral talar head sticking out of the side of the foot laterally. That's a 1. If you have to kind of feel for it, it's not as obvious visually. That's a 0.5. And a 0 is where you have a neutral position to the subtalar joint. The talar head is more within the ankle mortise, like it's supposed to be. Posterior heel crease, as we get to the hind foot, similar to the medial heel crease. 0 is no crease, 0.5 is a very superficial crease, and then 1 is a deep crevice. Equinus basically is at 90 degrees. Does it go above 90 degrees? That's 0. As it only go to 90 degrees, is 0.5. If it doesn't get up to 90 degrees, that's a 1. And then the empty heel. The empty heel is either a 0 or a 1. The empty heel is best described by touching your chin or your nose. So a 0 is your nose. It's kind of squishy and soft. If you touch your chin, that's a 1. So it's a little more, you can feel a little more firmish. What you're doing is you're feeling the calcaneus instead of the calcaneal fat pad, because the heel is more inverted in the 0 position. So it's going to be a little squishy, like pushing against your nose, versus a 1, which is like pushing against your chin. The results of the Ponseti method, a long-term study by Cooper and Dietz reported 78% good to excellent results at a minimum follow-up of 25 years. I mean, that's an incredible long-term follow-up. Success rates have been as high as 96.7% when it's followed appropriately. People try to modify it. There's really no modifying it. It is a specific technique. And many developing countries have started clubfoot projects. I worked on the Haitian Clubfoot project. I was the director of education for several years, working under Kay Wilkins, who was one of my professional heroes. He was the medical director for the Haitian Clubfoot project, and I was the director of education. Bracing is very important. The brace is prescribed at the time of the tenotomy. You're going to order your brace. That last cast is on for 3 weeks, so you need some time to get the brace in. Initially, the brace is worn full-time, day and night, for the first 3 months, except for when the child is bathing. Then the child wears the brace basically for nights and naps after that time period until approximately age 3 to 4. And a study by Ponseti and his group in 1980 showed the average or the mean bracing time was about 50 months. There are several different types of braces that are used. There are abduction bars. And I like the Ponseti brace myself. That's my preference. There are some bars where this is the Dobbs bar down here, which allows the kids to kick. But I like this Ponseti brace. I like the shoes. They're easy for the kids to get the kids in and out of. It really allows you to really lock the heel back and down. You can adjust the position of abduction also on them. It's really important when you're fitting the brace that you have the heels of the shoes at shoulder width. If they are too narrow, which is a common error, that's really uncomfortable for the kids, and they're going to cry and be miserable the whole night. And that's a common problem that leads to non-compliance. The bar should also have a little bend in it of approximately 5 to 10 degrees of convexity away from the child to help hold the feet in dorsiflexion, to correct for the equinus, to help prevent recurrence of the equinus deformity. The shoes can be permanently attached or removable. Most of the newer ones are removable. Braces can be somewhat expensive, probably around a little more than this now, but there are versions of the brace, abduction braces, called the Steenback brace, which are used in developing countries and recycled, which are very cheap. They're not adjustable in the amount of abduction too much. It's basically just a rebar that connects the two shoes, but it's a really cost-effective way in economically challenged countries where you're running a clubfoot program. The rationale for bracing is that in the Ponseti method of clubfoot correction, the main corrective force of the varus and adduction is abduction. So that's why we're trying to hold the foot in an abducted position and a little excessive abduction. And bracing is needed to maintain the foot in the same amount of abduction as the last cast, which is about 75 degrees of the thigh foot axis. The foot will gradually turn back into the about 10 degrees of external rotation. In the pull of the retracting fibrosis of the medial ankle ligaments, the posterior tib, long flexor tendons are strong enough to cause recurrence in the deformity of most feet. And the ankle joint, like I said, should be dorsiflexed to prevent recurrence of the Aquinas, and that's where you should have a bend in the bar. If you do not have diligent bracing, recurrence occurs in about 80% of the cases, so it's critical. With a compliant bracing program, the recurrence rate is only about 6%. And some of my personal conversations with Dr. Ponsetti when he was alive, he mentioned that their early results were a little bit less successful because they were not as diligent about their bracing, post-cast bracing protocols as they were later on in their documentation of the success of treatment. Without splinting, relapses recur really quickly. Once you get to about 5 years of age, it's pretty rare, and it's extremely rare once you get past 7 years of age. So it's important to monitor these kids throughout the years to make sure they're not getting any recurrence. Half the relapses occur between 2 to 4 months after braces are discontinued. And a lot of times what happens, our parents stop using the braces because the child foot appears normal, both just non-weight bearing and weight bearing. So they think that everything's fine and they can just kind of move on. Because it is a bit labor intensive, they have to fight the kids getting the brace on. Sometimes, they have problems with sleeping with the brace, and it's not always a fun experience, but it's really, really critical to maintain the correction of deformity and to prevent recurrence. Straight lace shoes really do nothing and should not be used instead of an abduction bar. Knee, ankle, foot braces like the Wheaton brace keep the knee bent at 90 degrees while abducting the foot, and that tends to cause recurrence of the Aquinas, so there's limitations with those. It's really important to educate the parents on the Ponsetti method and the post-cast bracing, and he always described it as making the parents feel like they're involved in the treatment of protocol by passing the baton of treatment to them once the bracing starts. So you've done your part as a physician, correcting the deformity with the casting and tenotomy. Now they have to maintain that correction, and they're part of the treatment team with making sure that the bracing protocols followed at home. You have to teach the parents how to apply the brace, have them exercise the child's knees together in flexion and extension to stimulate bilateral leg motion. And initially, it's going to be tough, and you have to just tell the parents that the child's probably going to have some sleepless nights, and therefore they're going to have some sleepless nights initially, and to just kind of fight through it. Eventually, the child will get used to the brace, and everybody will be able to get a good night's sleep. It's important to have a good initial follow-up visit just a couple of weeks after you start the bracing, just to check in on everybody, and then schedule them on a 3-month follow-up after that. And it's important to just make sure that this is adhered to throughout the course. You want to check to make sure that the brace width is appropriate, that you do not need to widen the brace, and checking against the shoulder width like we talked about, and monitoring the foot for overcorrection. One of the things that can happen is sometimes the feet can pull out of the shoe, and if the heels are starting to ride up, a lot of the shoes have little holes in the back of the heel area so that you can make sure that the heel's all the way down. If you notice the heel starting to come up, you can do almost like a little pad, like a little almost U-shaped pad that's upside down to in the shoe counter to help seat the heel down into the shoe if need be. If they're starting to develop excessive heel valgus or external tibial torsion, you can decrease the abduction from 70 degrees down to 60 or 40, something like that. Severe deformity should be braced until about age 4, mild to moderate between 3 and 4. So it's going to be a few years of bracing, and this is starting them right away with the casting. So you're looking at 3 or 4 years of casting. I'm going to turn the volume up on this one so you can hear it.
Which I treated in 1956, represent the longest recorded follow-up treatment of the deformity. Now in his 40s, Ross has painless normal looking, and functional feet. He's a pharmacist and stands most of the day. He regularly jogs and even participates in marathons.
So kids that have had posterior medial releases or more invasive treatments of their clubfoot, there's no way they can do those kinds of those types of activities that he was showing in the videos. They, their feet are just really stiff, non-adaptive. So they really lose that ability to have a mobile adapter. And then even trying to become a rigid lever to propulse off of it, it's usually a stiff foot, but it's not in the ideal position. So they do not function very well. So things like running, like that pharmacist was doing, is just doesn't happen. I started working in Haiti and doing a lot of clubfoot, and I was initially doing more surgical approach and wanted to learn more about the Ponseti method. So I started going out to the University of Iowa, and I really bonded with Dr. Ponseti. I was able to go to dinner with him and his wife a few times. They actually had me over to their house for dinner. It was still one of the kind of coolest experiences in my professional career, was being able to go to his home and have dinner with him and his wife, and go around his house and have him show me all his original Degas paintings, and just having pizza and beer with two 90-year-olds who were equally famous in their profession. His wife was a Spanish literature professor, and she was as famous in her profession as he was in his. So he's definitely one of my heroes, as is Dr. Kay Wilkins, who's also a pediatric orthopedic surgeon who I worked with in Haiti in the Haitian Clubfoot Project. But I think a hero is a definition is a brave man or woman, and which is a synonym as a champion. And I love this quote from Albert Schweitzer, that there is no reward for the work except for the privilege of doing it. And when you're in Haiti and you're putting on 40 or 50 clubfoot casts in a hot hospital with no air conditioning, and it's 100 degrees out, you're sweating like crazy, and you're dirty, and you've got plaster everywhere, and it can be, an exhausting day, but it's really a privilege to be able to change the lives of these children in treating them with something that's such a simple method that uh, can change the whole course of their lives. And it's so interesting because he started in the 60s with his treatment, even in the late 50s, and everybody just ignored him and didn't really pay much attention to him. And initially it was the kites method, and then they realized the kites method didn't work, and then they went to posterior medial releases, and then in the 70s and 80s. And he was just in Iowa City doing research to prove that the method worked, and really um, uh, continuing to just publish and publish and publish. And finally, after people started realizing the posterior medial releases were not effective and had significant complications and high complication rates, that there had to be a better way. And they finally took a look at Dr. Ponseti and his robust amount of research that he was producing out of the University of Iowa, and then gradually embraced his treatment to the point where it became the standard of care by the World Health Organization for clubfoot across the world. And it's such an inexpensive, simple method, if it's done correctly and you follow the process, that can have change the life of a child. And that's one of the reasons that I'm pretty passionate about it. And it's one of my favorite components of being a foot and ankle surgeon, is to be able to treat infantile clubfoot. He passed away in 2009. It was an honor and a privilege to be able to spend the time that I was able to spend with him. I made several journeys out to the University of Iowa, and I looked forward to every single one of them because I always learned something from him. He was very podiatry friendly. and he thought podiatrists understood the mechanics of the foot and were really uh, well positioned to do his method to treat clubfoot deformity. So we always embraced having visitors come, and he'd have people from all over the world come to be treated by him. And it was incredible being in his clinic. And I've never seen a 90-year-old man get kisses by so many women, moms who were just in tears and so thankful for him to be able to change their child's life with just 4 or 5 weeks of casting. And it was just really a humbling experience to be able to spend time with him and see the outcomes he got, and then be able to carry on that knowledge and experience to developing countries around the world. And our goal is to prevent um, the, this deformity that we see on the left. This is what happens when they're untreated, and especially in developing countries, not so much in the United States anymore, although you do see areas in the United States that there's delay in treatment or there's recurrence, and there are things that need to be done. But in other areas of the world, it just gets neglected, and it can lead to severe disability and really challenging surgical approaches to correct the kind of deformity that you see on the left. And trying to catch them as right when they're born. The youngest one, infant I've ever casted was an hour old. I was in Haiti one time, and they brought over a newborn baby that still had the tag on its, or the band on its leg, the contralateral leg, from being born about an hour before. And we started casting them after just being born for an hour. So if you have any questions, you can go ahead and put those in the Q&A session. I'll be glad to answer those.